Next, we hear from Glasgow, from Hao Gao, and this is SofTMech. Go ahead, Hao. Stage is yours.
Thanks for the opportunity. I'm here to represent the SofTMech Emulation Hub. Today, my talk is on the emulation and uncertainty quantification in cardiac modeling. So it's slightly a narrow topic. It's on the cardiac modeling. So I'm Hao Gao. And David Dalton, and he's a PhD, and joined the work with Dirk Husmir. Dirk is the leader of PI of this hub, and today he's in Prague. He's not here, so I'm here to represent the hub. Okay, so next. So our focus, one of the focus of our hub is on the cardiac mechanic, cardiac disease, and from the BHF we know cardiac disease is one of the leading cause of death worldwide, and unfortunately, more than a quarter of world deaths is related to cardiovascular disease. And see, for example, every day is 450 deaths, which actually is far more than the COVID-19 now. So our aim in the past 10 years, trying to understand, use the mathematical models, and to understand the cardiac disease from a biomechanical point of view, and also we're trying to whether we can use the model to predict the outcome of the patient, or we can predict the treatment. So that's our aim, is trying to use mathematical models, and so that is what we've been developing in the past 10 years. We starting from the clinical data. One of the data we use is cardiac magnetic resonance imaging, and then we can construct a personalized models, the cardiac models. So that is the final element model, and from that we can calibrate our model to the data. So that will provide subject-specific biomechanical factors like the stress, strain, and the stiffness, and the contractility. And one of these, we're trying to integrate them together and to use a statistical approach and trying to classify the patient into high risk of or low risk in developing heart failure. So while this looks quite fantastic, promising, but one of the problem is it is very computational, expensive, and sometimes we need to run days, weeks, and months to calibrate one patient model. And that is not what we want. We want something fast. So that's the aim. And it's kind of the motivation. We have this emulation hub. So that is, I only got one page for our hub. It's not too much. So that is a SofTMech statistical emulation and a translating hub as led by Dirk Husmir. So he's in the middle. So this that hub is co-led by two institutes by our university, Glasgow and Sheffield. We also have like 4 packages, but also more. The first package is on the coronary and pulmonary muscular biofluid mechanics related. And then the second package is the cardiac mechanics. So that's risk of heart failure post myocardial infarction. So this is one of the biggest team in our hub, and I was involved in this, mainly involved in this package. And the third package is on the cardiac electrophysiology, sudden cardiac death. And the cardiac electrophysiology was one of the very big topic in the cardiac disease. And then the fourth work package is on the personalized drug delivery. So that stent in the if the coronary is blocked, then that's the treatment we use for the patient. So those are kind of brief introduction of our hub, and if you want to know more about the hub, you can talk to me. And like the collaborating fund we have, and also the events we are currently organizing, and I think there will be some other events together with other hubs. And so okay, now we came to the cardiac modeling. So one of the focus is on the cardiac injury. So like for this, the left part. Left figure is the myocardium, the muscle of our heart, which is responsible for the pumping of the blood to the body. And one of the main disease here is heart attack. After heart attack, and the tissue will be healed, and with the scar tissue, you'll see the scar tissue is different from the other part of the muscles. And one of the questions is how big the difference, and can we detect the difference? Can we understand the difference, know the difference from the in vivo measurements? Because normally we won't be able to get a slice from patient, the sample. And what we have to rely on is the magnetic resonance imaging or some other in vivo measurements. And then we can try to infer the material properties of the heart. So that is what we did, is we call it personalized category modeling. So here today I will only talk about the diastolic part, is the passive feeling part of the heart. So starting from the imaging and what we need image processing, and our hub is more working on the modeling side. So we still have to heavily rely on the manual segmentation. So we do manual segmentation, and then we can reconstruct the geometry. So that is the one. The better can use this mouse. So we have this left ventricular geometry 3D, and also we need the pressure, and also we need a model which can describe the material property of the muscle. So that is the constitutive model. So that is in the bottom, and for this model, it's highly nonlinear, and also we have a bunch of parameters, which normally is not, we can't measure these parameters directly, and then one of the problem is, okay, we want to know what are the constitutive parameters of the patient. And what we do is we can run the simulations, the forward simulator we call, and then that normally takes several minutes or hours to run the simulation. And then we can calibrate the models with the measurements on the right side. So that volume and the strain we can extract from the measurements, from the data. And then we can compare, quantify the difference, minimize the mismatch, and then we can infer the parameters. Well, the whole process can take, like, say, we can solve this problem for one patient if the patient can wait for 2 days or more. But normally this probably is not the case if the patient has a heart attack and we need to act very quickly. And also we ignore the uncertainty. So for this kind of work, we don't have the uncertainty quantification. I think I heard that a saying, if the model doesn't have an uncertainty quantification, the model could be useless. So we want to know the uncertainty of the models. And then so that what we trying to do is to emulate the cardiac mechanics models. We're starting from the forward simulator. So that is the finite element or biomechanics model of the heart. And we can run thousands or hundreds of thousands of simulations using a space design approach. And then that will take weeks, months even. And then we have a big data. So that big data is coming from our models, high fidelity biomechanics models. We know the physics. And then we can use this big data and then to train the statistical models, like using the interpolation or regression approaches. And there are various approaches, statistical models, like the Gaussian process and the polynomial chaos expansion, and deep learning neural network, and the graph neural network, and the physics informed neural network. Those models has been used in the quantum mechanics field actually. And so after train the emulator, then we can use this emulator to replace our simulator to calibrate the models so that we can match the patient data, provide a faster solution so that doctors and will have the say personalized biomechanical factors coming from the emulator to make a in-time decision making in the clinical settings. So this is kind of the ultimate aim of our of this project. And so this is one example we did before, the Gaussian process with fixed geometry. So that is only applied to one patient. So the Gaussian process is kind of one of the standard models in the emulation. And you probably came across the first page. And then we have we need the input space. Here with a fixed geometry, and we only vary the constitutive parameters, the material parameters. Like here we use 10,000 simulation data. And then we can train a Gaussian process. And the output space is the volume and the strain. So the strain is how the heart contracts. And then so you see the results, the prediction for the volume and the strain, they're quite well. And the prediction axis is very good. And then we use this trained emulator to apply to an inverse problem and compare the same problem using the simulator. So the red curve is the stiffness estimation using the simulator, and the dashed black line is coming from the emulator. And you see the difference is quite small, and while the computational gain or the computation cost from the emulator is much smaller. It's 3 orders magnitude acceleration. You can see using the simulator, it takes 3 to 7 days, but using the emulator, it only takes like 15 minutes, which is the time we want to achieve. So you can find the details in the 2 papers there. And then, so that previous is a fixed geometry, and we know every much different. Of course, the heart is also different for each person. So that here is an example of 5 left ventricular geometries from 5 different patients, and we see they are very different. You can see just from this reconstructed geometry, and so that geometry is represented by the nodes in the surface, and we know each node has 3 components, the X, Y, Z, in the 3-dimensional space. In total, for one geometry, we need 70,000 degree of freedom to represent one geometry. That is too big, and especially if you want to use this geometry for the emulator, to train an emulator. So we need to rely on the dimensionary reduction. So what we need to do is, okay, we need to reconstruct a big data of the geometry. And the first step, we'll find a low dimensional representation of the real geometries. And here we use the principal component analysis, and also we applied autoencoders that is coming from neural network. And then after this, we can combine the material properties with no dimensional representations of the geometry, and using a space finite design approach, and then we can design a test sets which combines the geometry and the parameters. And then we can map the space finite design geometries back into the real geometry space. And then we can run the simulations in the 4th step. So that will give us enough bigger data, which can be used to train the emulators. That emulators will include the geometry, G, and also the material parameters, theta. And then we can emulate the output, Y is the volume and the string here. So we tried various different approaches like sparse GP, local GP, and neural network. And here I can show an example. So this is a neural network emulator. And for this one, we have the output, we have the input space, theta is the parameters, and G are the new dimensional representation of the ventricular geometries. And this neural network has 2 hidden layers, and each hidden layer has 100 neurons, and the output are the volume and string. And also on the right side, you see the prediction versus the ground truth data that's coming from the models. You see the prediction is quite well, it's quite good. So that is the neural network emulator. And for this one, we also have to rely on the dimension reduction of the geometry. So that means we use here we use the principal component analysis based dimension, 5 principal components. And well, previous emulators, the geometry is represented in the node dimension, and can we directly use the geometry? So that's the work we did recently, is the graph neural network. So that means now we don't rely on the dimension reduction. We directly use the finite element representation of the geometry. So that is 70,000 key dimensions of the geometry. And here for the graph neural network, you will need to construct a graph representation G, the capital G. Capital G has V is the nodes of the finite element meshes. So that is coming from the finite element models. And E is the edges, directional edges, and theta is the material parameters. So the graph neural network and use the 3 steps: encoder, processor, and decoder. So in the encoder step, you can encode features. Here we use 80 features and for each node. And then in the processor step, that will be, so that internal features will be updated through the message passing. So we can pass in the messages from one node to the neighbor nodes to another neighbor nodes. And then in the decoder stage, and the displacement field, like the dynamic feeling of the heart, will be predicted by the decoder state, by the decoder step. And finally, we can deform the ventricular geometry and through the from the decoder predict the displacement. Then we can simulate. We can predict the dynamic feeling of the heart of the ventricle. So the good things for the graph neural network is that we don't rely on the dimension reduction. So there's no error uncertainty induced by this dimension reduction approach. So also we use augmented graph. So that is something we tried, and we found this is very important to improve the computation efficiency. See, that is an illustration for the layer 1. It's completely come from or directly come from the finite element representation or the mesh. And then because we need the messaging passing, so you can think about if you want to pass in the message from the left corner to the right corner, and it will take many steps because of the edges. And then what we do here is, okay, we can cluster the layer 1 nodes into less nodes in layer 2, the virtual nodes. So that means for this example, it's 96 nodes in layer 1 and 24 virtual nodes in layer 2. We can further cluster the nodes in layer 2 into even less nodes layer 3. So that means, and for the virtual nodes, so that nodes in layer 2 and layer 3 we call the virtual nodes, and the virtual nodes has collection to the layers behind below, and also has collections within the same layer. And then that means now our messaging passing can take a shortcut. So for the left corner, that messaging passing, we can jump to the nodes in the layer 1, and then jump to the nodes, virtual nodes in layer 3, and then take another path from layer 3 to layer 2 and layer 1. So that means only 5 steps on our messaging. The message can be passed from the left corner to the right corner. So that's a shortcut. And we found a very significant computational efficiency can be achieved in using this approach. And then finally, it's just a result using this graph neural network. And so these are the 2 cases we simulated. One is so the red surface coming from our simulator and the purple surface coming from the graph neural network. We see the differences very, very small, and virtually they are overlapped, and the volume difference is about 0.5%. So that means that graph neural network emulator can accurately approximate the cardiac mechanics model, and also we can gain a significant computational efficiency and over the finite element simulator, and the prediction time is within seconds if the graph neural network is trained or is trained. And that we found that it's kind of 5-order acceleration. And also there's a good thing, advantage use graph neural network is there's no dimension reduction, especially if we want to simulate the myocardial infarction. We know the infarction is a local region, so that the shape can be very different. It's very difficult to do the dimension reduction. And for the graph neural network, we can just use the real geometry and the real domain. So that will be one advantage of use this graph neural network. So we've been talking about emulator, and then now come to the second topic is uncertainty quantification. So how the emulator can be used. One of the way you can use is for the uncertainty quantification. So we have the model, and also we have the parameters. Then we can say first we can in the up we can do the sensitivity analysis. So this will assess the effect that parameters affecting the model output. So like the constitutive parameter and then how this will affect the pump function, like the volume and the strain. So that is the quantity of interest. And also have the measurements like the cardiac magnetic resonance imaging. And that from that imaging data, we can extract the same quantity of interest. And then we can look backward how this quantity of interest will affect our parameter through the inverse uncertainty quantification. So that is the top one is the forward uncertainty quantification, and the bottom one is the inverse uncertainty quantification. And then so that is the myocardial model I mentioned before. It's quite complex. It has 8 unknown parameters, and the parameters are highly correlated because inside there's exponential function, and it's quite complicated, and not every parameter can be uniquely identified. So there are different ways trying to reparameterize this model. Like the left one is only use the first 2 terms, and also they introduce other constraints on the parameters. So in the end, there are only 1 parameter which needed to be inferred from the measured data. And the right one is the one we used before. So we reparameterize the parameter 8 parameters into 4, and using some ratios. And there's a new physical. It's based on our experience, and it's not based on comprehensive sensitivity study. So what we want to do, okay, if we can carry out a sensitivity study on this model and see what kind of reparameterization approach we can use. So that is the global sensitivity analysis we recently carried out. So we try to access the contribution of each parameter to the variance of the quantity of interest. So you can look at the individually. So this is the first order super index. You can also look at the combinations. So that is the total effects super index. And this normally will require specifications of prior distribution of the parameters. And we've been looking at the uniform and local uniform. And actually our results are quite similar for these two priors. And that is kind of a forward uncertainty quantification a priori in nature. So that is, we look at these two super indices. One is the first order super index, and the second one is a total effects. So you look at the individual parameters, and also in the total effects, you also look at the combinations, the interactions between the parameters. And then that is the results for this for the Myocardial model. And we look at, so the left one is on the volume, the predicted volume from the parameters, and the right one is on the string. So if you look at the left one, we see the ventricular volume is highly affected by the four parameters A, B, AF, and BF. So that the right one I made a note keep, which means those parameters maybe could be identifiable. They're quite important. And the other four parameters, AS, BS, AFS, BFS, and they have a very low super indices, which means you can either to remove these parameters from the model, or you can keep them fixed to the population-based values. And then you can find similar results for the string, using the string as quantity of interest. So that means, okay, and for this model, and we probably, if we knew we can measure the volume and the string, and the best way to reparameterize the model will be keep the first two terms, and we might be able to infer the AB and the AF, BF, the four parameters, but the other four parameters, we need to put that question mark, whether you want to keep it, or you can just keep it, use the population-based values. So that is, you also can find the details in this paper. Okay, so next, also we tried, I've been talking about inverse uncertainty quantification that will involve the MC. So we use the Bayesian Inference. So the P theta is the unknown parameters, and Py theta is the likelihood, and P theta y is the posterior distribution of the parameters based on the measurements. And so we look at the four identifiable parameters from the global sensitivity analysis, forward uncertainty quantification, and see how those parameters are identifiable from the measurements. And you see that figure is the density, is the kernel density from the Bayesian Inference. And you will see the blue curve is A, and the green curve is AF. So which means A and AF, the two parameters, are more identifiable because you see the peak, and compared to B and the BF, which is quite flat. So that means, okay, and from the inverse uncertainty quantification, it looks like we can identify A and the AF quite confidently, but probably that's very uncertain about B and the BF. What we can do with this, and you will think, okay, we probably can, whether we can introduce new measurements which is very sensitive to B and the BF, or we need to find other ways to estimate B and the BF. So that is the inverse uncertainty quantification of this model. So the last part is operator uncertainty. So what about the uncertainty? As I said before, our models is constructed by operators. It's manual reconstruction, manual segmentation. So there are a lot of errors introduced by the operator. So first part is the reconstruction part. We'll have that manual segmentation error, and also in the measurements, the right side, we're trying to calibrate the models. We need to measure the volume, the string. Also, there will be errors. And then finally, also we have the dimension reduction error that is introduced by the 5 PCA, for example, here. And then so this year we started to look at the operator uncertainty. So we have like three operators with different level of experienced users and inexperienced users. And we also include one deep learning based approach and 6 patients coming from COVID-19 patients with some cardiac symptoms. And also we compared the PCA reconstructed errors compared to the operator uncertainty. You'll see the figures showing the geometry reconstructed by the 3 operators. You'll see that's a difference, which is quite obvious. That means there will be operator uncertainty in our model, and we need to quantify how those uncertainty affect our model prediction. And so that's the purpose. So the deep learning based geometry reconstruction. So here is we use 2 neural network. The first step is the segmentation, and the second part is the reconstruction. So the input are the images directly, and the output are the geometry to find the animal mesh. So that is completely bypass the human operator operation. So that is the result. First one is on the segmentation comparison. That is a Diastole score on the short axis image. The bottom is for the long axis imaging. And normally the long axis image is slightly difficult to segment with high accuracy. But in general, we say the operator uncertainty and also deep learning, they are comparable. The results are not that different. So that is good news for us. And we can rely on the deep learning approach and for our models. And then also we want to look at how the dimension reduction, the errors introduced by the dimension reduction, like we compared the operators, deep learning, and PC components from 5 components to 10 components. And in general, you will see for the 5 PC, the errors and the niche error has achieved for 3 patients. And the others are in general, the errors introduced by 5 PCs comparable to the operator uncertainty or operator induced error. So that means, okay, we are quite happy with 5 principal component reconstructed geometry. So that is kind of ensure we've been using these 5 PCA for a while. Well, I think the important question is how that this uncertainty introduced by the operator or from the deep learning approach, and this will affect the myocardial stiffness estimation or the biomechanics factors. So that is ongoing work. So finally is the calculation. And so first of all, the computational expensive cardiac models can be well approximated by various statistical surrogate models, like the Gaussian process neural network we mentioned. And the pre-trained surrogate models can provide a faster solution for to infer the unknown model parameters. And also the global sensitivity study on the uncertainty quantification can help us to reformulate the models and to reparameterize the models. And also our preliminary results suggest that deep learning based approach and induced uncertainty is comparable to the operator uncertainty, and also including the dimension reduction part. Thanks for your attention. I'm happy to answer any question.
Thank you so much, Hao. Thank you. Are there questions? Yuan.
So my first question is, what do you think would be the biggest challenge to move from a LV only model to a full heart model?
I think the first part is how to reconstruct the personalized geometry with a very high accuracy. So that we've been struggling to work on that for a while, and we have the final solution for that. And then also you have to include other physics models like electrophysiology and also the heterogeneity included in these 4 hard models.
My second question is about the GN part. So I think it's a very natural choice to use the nodes from the dynamic mesh because we already got that.
Yes.
So we also do the mesh synthesis analysis in that GN. So I wonder whether you do something similar in GN. If we have a more cost graph, what would the results be and what's the inverse like?
I think I remember we tried the sensitivity study on the mesh density. I think it's not that sensitive, as you can train the models with very high decent or with decent mesh nodes.
I think in order, okay, Ed, go ahead. Quick question.
Like, well, once you have the model of the heart, what is that used for, like downstream? Is it like research or clinical?
So the aim is we're trying to quantify the property of the muscle or the heart muscle. So we normally heart patient will have like two phenotypes. One is the diastolic heart failure, the other one is the systolic heart failure. So diastolic heart failure is related to the stiffness. That is the work we've been focused on. If the heart is too stiff, we know the heart is not able to fill properly, and then the pump function will be reduced. So that is one part of this project, and we found that stiffness could be a biomarker used by the clinician. And as long as they know, okay, when they get a patient and they can estimate the stiffness, and they can use this stiffness to predict whether the patient will recover under some treatment.
Great. Is that okay, Ed? Then I'll suggest we take the other questions to the coffee break such that we can actually have one.
Okay.
Thank you so much, Hao, for a really great presentation. Thank you.
Thanks.
And we come back here at 12. Perfect.
It's pretty Dr. Kat.
Thanks so much.
Thanks for the webinar.
So because there is, I mean, you show there is quite a
Yes, yeah. So now what we do is we